You've had hormones in your body all your life. We're just putting it back in.
Right.
It wasn't dangerous for you before. Why do you think it's dangerous now? Hey everyone, welcome to today's episode of the Medical Disruptor, the show where we challenge outdated medical norms. I bring you innovators, boundary breakers, trailblazers who refuse to accept the status quo. Why? Because we have to revolutionize the way we approach wellness so that you can feel better, live healthier, and take back control over your health. And today's episode is no different. I'm joined by Dr. Camille, an ER physician trained at the highest level who did everything right until her body crashed. Years of unexplained fatigue, migraines, infertility, anxiety, totally dismissed by everyone, even though she's in the profession, treated in silos and chalked up to stress. What finally turned things around? A diagnosis no one thought to look for: severely low testosterone in a relatively young woman. In this first part, Dr. Camille opens up about what it took to unlearn conventional dogma, step into functional medicine, and reclaim her health. If you've ever been told everything looks normal when you know something isn't, this one's for you. Camille, I'm so excited to have you here.
Yeah, it's great to be here. Thank you.
Of course. So as all of my listeners know, we searched the globe for disruptors, people who first got schooled in some sort of conventional medicine, and then they came over to the dark side. And you are very much, you're an ER doc.
Right.
So tell us what pushed you over to the dark side.
It was a culmination of things. I'm sure, like most people, it wasn't just one thing or one moment. Yeah, so I was conventionally trained. After medical school, I actually had a military scholarship. So I went into the Navy, and this was like just after 9/11. So I spent 5 years actually in primary care, deploying with the troops and whatnot in the military, got out, went into an emergency medicine residency. And so by that point, I'd already been in medicine for 10 plus years, got my first attending job, bought a house, like all these things. And so I would say two kind of integral things happened at the same time. Got my first job and started seeing patients and just noticing like people are sick, you just, and it was really at the time, it was like belly pain. I was always like, belly pain was like the thing, right? Every bed, I'd go bed to bed to bed in the ER, and everyone's got belly pain. And I'm like, are you taking your acid block? Yes. Are you seeing your GI doctor? Yes.
Yeah.
And it's
Scan.
and it's like the same people in the ER. You should not have return customers. Like I
Wow.
start to get to know people, like you're always here. Like what is going on? Like going on in my mind, because I think if you're paying attention, the ER is a great place to see patterns, because I'm seeing 25 to 30 new patients every day, getting a history, and I start going, gosh, everyone's like on the same meds. Everyone's got the same. So what's going on with that? So my mind is thinking, right? And at the same time, I had my own, what I like to call health implosion. And here I was finally, like after all of these years, finally, like I made, and I had my first baby. I was already in my mid 30s, and my body just imploded.
What does imploded mean? What happened?
Yeah, I didn't know what it was, right? But I had my baby, and then I tried to have another one, lost that one, and tried to conceive again. And I was like having infertility issues. Then I was just like exhausted all the time. Like I could sleep 10, 12 hours. And I just remember the first thought that would go through my head every morning was like, boom, I'm so tired. And this just kept going on.
So you blamed it on the job and on motherhood, and you're like, it'll get better. It's got to get better. And
so you just keep trying to plug along. And all the while I'm like seeing fertility doctors and trying to get that. And I also struggle with migraines, and they just became unreal. This went on for 5 years, this misery.
If I may, I'm assuming, since you're at that point so ensconced in conventional medicine, you're assuming they're not related. The infertility and the migraines.
Yeah.
Yeah.
I'm seeing a neurologist. I'm seeing a fertility doctor.
Different parts, exhausted. Different offices. Nothing's connected.
Yeah. And then I started struggling with like depression, and then started even having anxiety, which I've never struggled with before. And I like to highlight that as I'm seeing this fertility doctor, who's an OBGYN, who's on a board of a major residency program, he says to me, you have no testosterone, but you can deal with that after you have your baby. Okay.
I'm gonna leave right now. I'm sorry. I'm just gonna.
It sounds crazy, but like,
and you're like, yeah.
I'm just like, okay, like he's the fertility guy, right?
Yeah, and it has nothing to do with your fertility. So who cares about you?
I know. And so that always stands out. I remember that because I'm just like, this is so insane. They don't even know that like testosterone matters. So, anyways, he proceeds to pump me full of all kinds of things. I do end up having a baby in this like toxic milieu, horrible pregnancy. I'm still
Jeez.
actually trying to recover my child who was born with some health issues from all of this. And then after I have this baby, I'm still miserable. I end up actually like having a panic attack in an office at work, like in an ER, and I quit my job the next day. And
Wow.
I was like, I have got to figure this out. Talk about rock bottom, right? You've been training for 10 plus years.
Wow.
I got my first job. I have a baby. I can't even take care of this baby. I'm like in a room all the time with migraine. It was insane.
And wow, first of all, you weren't kidding when you said implosion. Holy
Yeah.
cow.
Yeah.
Holy cow. So sorry you went through that. Oh my God, so sorry. We're so not treating our women correctly in medicine. Oh my God, that's crazy. And if I imagine that it feels very much mental, like you're just not resilient enough and you have anxiety and you have depression and like different variation of it's all in your head. And if you could just push through it,
Yeah. Because
like
that's
how
what you
much,
do, right? You just keep trying to go. And I
of
mean, I
course.
don't even know how I was like functioning. I was still showing up to work, still like
Oh my
whatever.
God. By the
I
way,
mean, like
why did you have,
I have a very supportive spouse. But yeah, it's just, why can't I do this? Everyone
okay.
else is doing it.
Yeah,
And
yeah.
I
I'm
think
so,
like I just can't handle it.
so now I'm a loser and we have all these negative talk and that, oh my God, so hard to get out of that. By the way,
Yeah.
what was the infertility issues? Was it PCOS or something else?
No, it was literally low testosterone.
Holy cow.
Yeah. So after that, I was like, finally, okay, something's got to give. I clearly have to be my own doctor, right? I have to figure this out. And I was like, something clearly hormonal is going on here. And so I ended up finding like a functional medicine doctor doing the hormone thing. They're like, you have no testosterone, like
One
got on
second.
testosterone.
Pause real quick for a moment because even that sentence, I went to find a functional medicine doctor myself because I went through with my wife's journey. She was really sick. And correct me if I'm wrong, but that decision to go seek out the quacks, it's not an easy decision to make. Was it easy for you? Because I was like, this is definitely witchcraft / nonsense, the first one. Or were you already ready?
I was ready. And I do come from a family that we're definitely out of the box thinkers.
Okay.
So it was actually partly my family that was like, even from the minute I got out of residency, they were challenging me on,
Okay.
I'd be like, you have acid reflux. Here's your Prilosec.
Here's
And they'd
the
be
Prilosec.
like,
What do you
well,
do?
I heard that it's actually that you don't have enough stomach acid.
Right. And you're like, that's ridiculous.
Yeah. So they were always challenging me.
So there was holes already in your.
Yeah.
Okay, that's interesting because like for me, like I went to the quacks just to prove them wrong. And
Yeah.
that it's not going to work. Except it completely reversed my wife's issues. So interesting. You were already there. You came from a family that was open. That's
Like my mom always did quackery.
yeah, all the crazy
I mean,
stuff.
I remember my mom telling me 30 years ago she saw an ND, a naturopath. And I'm like, ND? You mean ND? No, ND. And we're all like,
All what kind of
see,
nonsense. Okay, so you already went through the phase of calling them quacks.
yeah.
Okay.
Yeah.
At some point you have to
Like
go
I
through
was
that
just at a
phase.
point where I was like, I'll do anything. And
Yeah.
like, I think my sister was like, oh, people see this person for hormones. So I was like, it seems like
Okay.
a hormonal issue. I'm just going to
Sure.
go see this person. No one else had helped me. You have an OBGYN fertility doctor who doesn't know hormones, right? So I
Yes,
was,
yeah.
I'll do anything.
Ah,
Yeah.
okay, oh
Yeah,
God. So
like,
agitated
it was
already.
actually a really easy fix, right? Like I got testosterone, fixed my hormones, instant life back. Instant.
Instant.
I'm losing weight that I never could lose from my first pregnancy, get down to my old college weight, instantly have energy, instantly moods back to normal, no depression, no anxiety. Oh yeah. And I naturally conceived my third baby,
Oh my God.
at the age of
How
40.
insane.
Yeah.
How
And so that
insane.
really was like my passion, right? I was like, oh my gosh, this is amazing. Everyone needs hormones. Like and from that moment on, I really went full bore into, I started with just hormones. Let me learn hormones. But then it's like oh, what's this over here? What's this good
Yes,
stuff?
yes,
So
totally.
then I went all in, but yeah, but hormones are still my
So
passion.
You're the second MD that I had, female MD, that she crashed and burned in her career, also secondary to low testosterone. She was OBGYN, never learned about hormones. Went to school with the old study when the old study said don't touch hormones. And so she crashed and quit just like you did. She was like, I'm out.
Yeah.
And then
Adrenal stress and testosterone have a big interplay. So it's really not surprising that it's like that's where a lot of we're seeing the high achievers,
can you explain to our audience why that happens?
Yeah, there's just when we talk about like the HPA axis, like that's the whole thing is like balance, right? And that's why I get hung up on like, why are we just talking about estrogen or whatever? It's like we need balance, right? And so we need balance with our thyroid, we need balance with our adrenal glands, and we need balance with our hormones. And there's just an interplay between the adrenal glands, specifically with DHEA and testosterone, and our ovarian function. And so when we get really stressed, the body starts really trying to convert things and whatnot, and it crashes our DHEA, and which crashes our testosterone as a byproduct. You see a lot of those like high achiever women or women in big careers, whatever, will have like testosterone issue. Not that everyone, like many women can, but specifically in those areas. Yeah.
No, it's great. It's great that you're surfacing this. I don't think it's very interesting. Everyone comes in, so many women want their hormones tested. And they're always thinking about estrogen and progesterone. And honestly, getting them tested doesn't yield a lot in the perimenopausal or menstruating woman. But testosterone is never tested.
Yeah. I talk about testosterone a lot because I think for me, because it was so transformative, but also it is like the forgotten hormone. Like I always like to say, women need testosterone too, right? It's OBs are still, they're stuck on estrogen. Like estrogen, like the be all end all, right?
Yeah.
Occasionally someone will throw a little progesterone in there, but like I even have women who will come to me as patients because their OBs will give them estrogen and progesterone, but they will not under any circumstances give them testosterone.
Yeah.
I really
scheduled drug.
Yeah, because it can be just so, and what a lot of people don't realize about testosterone is how important it is for mood, specifically anxiety. So you take someone who's really struggling with anxiety and you test their testosterone, 9 times out of 10, it's low. And so you think about testosterone, muscles, energy, maybe libido, but no, mood, depression, anxiety. And this is really well documented. And I see this all the time. If you can fix their testosterone, you can fix the anxiety.
That is so important. It's so interesting. I don't think we've spent a full episode on this, on testosterone deficiency not in the postmenopausal woman. What we talk a lot about, right, is an elevated testosterone in our PCOS women, right? So PCOS is really covered. And then we know, just as a quick recap for our audience, right, if you're on glucose overload, it sends certain signals to your ovaries. And one of the many byproducts is your testosterone is elevated. So how do we know someone has PCOS? One of the things is often an elevated testosterone. So we know that end of the spectrum, but we definitely have not surfaced enough the 30, 40-year-old woman who just has no testosterone.
Right.
And this is the woman who's doing everything right. She's trying to eat well. She's trying to go to the gym. She's trying to doing all the do's, and she's just not getting it together. This is definitely under-tested, and this is easy, right? Because progesterone and estrogen are hard to test for in the menstruating woman. What day are you coming on? What are the levels? But testosterone, test that any day.
Yeah.
Oh my God, this is really eye-opening. Like everyone listening should go get their testosterone test.
Yeah, for sure. Definitely. If you think about women come in, they're like, I have no energy. I'm gaining weight. I can't lose weight. I can't even work out. It's a testosterone. And it's like people feel, and they try to excuse it away, right? I'm in my 40s and I have kids and I work full time. And I'm like, yeah, I hear all of that, but still, you should have energy and the stamina and the mood to be able to do that.
You're so right. I will see women later in life and say, it's so much. I'm taking care of my parents. I'm taking care of the kids. And it's just that hard. And I'm like, think back to when you were 20, when you were probably going to school, couldn't put food on the table or struggled to pay the bills, had the little ones running around from here to that. That was definitely more stressful back then. It was guaranteed more stressful back then when they were little munchkins and you had the bag and the stroller and you were able to manage that. So back then things were definitely more stressful for you. You really want to tell me now, as you're approaching like the height of your career, generally speaking, things are a little bit better than they were financially for many people. Now is when you're crashing just because of stress. That doesn't make sense, right?
For some reason, we've just been sold this lie or whatever it is, or just this is inevitable. As you age, You will have low energy. You will just naturally feel bad. You will naturally not want to. And it's like, most believe it. But I think that's where hormones give me so much passion, because I'm like, no, like I reject that, because when you get your hormones optimized, suddenly you feel great again. You can do the things. You can run your business. You have time for your kids. You can do all those things.
Tell me about, people are worried about testosterone. Dispel the myth for us about, oh, testosterone, I'm going to be too big, I'm going to have facial hair. Dispel the myth for us.
Yeah. Well, there is a lot of research that shows like I said, I always tell women, we need testosterone. We just need small amounts as compared to men. So it's just all about the dose. Everything's about the dose and timing. And so I think if you keep it, what's interesting is that I read something that said we actually make 3 times as much testosterone as we do estrogen before menopause.
Wow.
Yeah, most of us don't think, we think testosterone's not a thing. And it's no, we actually made a lot of it. But then, of course, with age and with decreasing ovarian function and the adrenal stress and whatnot, then we're not making it. So when we don't have it, it's noticeable. And so it's like if you got on estrogen or you got on progesterone, yeah, if you took way too much, you might have some side effects. But generally, that's the goal, is we're doing like physiologic doses, right? We're not doing super physiologic dose. That's where even like the Women's Health Initiative, they got into trouble. They're doing these mega doses. We're just saying, support your body, get it back to the optimal levels. And when you do that, you shouldn't have any facial hair, deepening voice. Again, I think there's so much, even in men, there's this steroids go to anabolic steroids, or testosterone is anabolic steroids.
Right.
No, these are two totally different things. We're talking about what is naturally made in your body and just giving it back at physiologic doses. And when you do that, you could virtually eliminate all negatives about hormone replacement in general and get all the benefits. But even there's a lot of studies that show if you have, particularly in men, they've done a lot more studies on men. There are studies too, but like if you have low testosterone, you have increased morbidity and mortality. That's if you have low testosterone, you have increased risk of dementia.
100%.
All these things. So it's like these things are supportive for us, and it's just because we're women doesn't mean, but we produce it, and if we give back those physiologic doses, then we have the benefits and none of the dangers.
That's it right there. Like the dementia thing with hormones is that's what sealed it for me. I was already on hormones, but learning that there was no question. And physiological, if I'm not mistaken, please correct me if I'm wrong, right? We're talking about up to, if we're testing blood serum, up to like about 40. Whereas men start at 300, below 300 is low.
Yeah, and they're up to 1,000.
300 to 1,000 is male range. And for women, we're talking about 0 to 40.
Yeah.
So we want to push them close to 40. We're not trying to get them to 100.
Exactly.
That's when we start having trouble.
So we're just getting them back to the scale where is right for them.
Yeah. And the other thing I tell people in general about hormones is, look, you've had hormones in your body all your life. We're just putting it back in. Like, it wasn't dangerous for you before. Why do you think it's dangerous now? I actually just had this conversation with a patient who was like, I just want to do everything naturally and I want to take supplements. I'm like, and I get that, but this is natural. This is putting back in. This is not like, let me give you Ambien to sleep. That's not natural. This is, you can't sleep because you don't have progesterone anymore, which you've always had. Let's put it back in.
Right.
And then there was like, it's not from a natural source. And I'm like, no supplements are really from a natural source. They're all from some sort of factory. Unfortunately, we don't have a testosterone fruit that we could take. I wish. So this is what we have to do to get it.
Yeah, there's just so many myths about, you have to spend so much time just educating people about hormones.
Yeah. What do you like? Creams, pellets, injections? What's your method?
Typically, so my other kind of passion aside from testosterone is progesterone, which I do orally. And I think, and to me, I feel that the only hormone you should ever take orally is progesterone.
Agreed.
And that's because we know that the way that it passes the metabolism and goes through the liver, then it crosses the blood-brain barrier and stimulates GABA. And for your audience, GABA is the only calming neurotransmitter that we have. All of our other neurotransmitters are excitatory. So when we lose the ability to stimulate that calming neurotransmitter, that's when we feel like that irritability, that insomnia, things like that. And so that's the other thing, is that particularly in perimenopausal, just estrogen gets all the glory. So does menopause, right? Nothing happens until menopause. So for about 10 to 15 years, you are lacking these hormones, right? So perimenopause gets neglected. And during that phase, you're having decreasing progesterone. And I'm really big on giving like oral progesterone during that time, because also what I like to explain to women is that as you progress through perimenopause, which can start as early as your late 30s and go all the way till whenever menopause is, like in your early 50s, that's 15 years. Your progesterone's dropping, but your estrogen isn't dropping as fast. So
Right.
then you become estrogen
Estrogen
dominant
dominant.
during, which has a lot of health implications. And that's the other thing that's crazy to me is, you want to talk about breast cancer. I'm like, I'm tired of talking about breast cancer awareness. Let's talk about breast cancer prevention, right?
Yeah.
And
Preach.
the big time that breast cancer is diagnosed is actually, if you look at graphs, is during your 40s and 50s, right while you're estrogen dominant. And so an easy way to support, it's like, what if we just gave everyone progesterone during that time? My other thing, I'll segue into being an ER doctor, is that so many women come in their 40s bleeding, right? They're all bleeding. And
Everyone's bleeding.
what is the treatment? A
Proge-
hysterectomy.
Oh my God,
Right?
yes.
And I'm just like, I was talking to some people the other day. I'm like, this is so 100 years ago. We are so in the Stone Ages. This is so barbaric to just cut out these organs.
Oh my God.
Like,
Like how many organs of women?
literally-
That's what I say to people all the time. And then they get your gallbladder removed and you get your hysterectomy, or there's no more body parts to remove.
I'm like, where are the OBGYNs on this? Because estrogen is proliferative hormone. Estrogen is going to cause proliferation of your uterine tissue and your breast tissue. And that's why it's so important to be balanced with progesterone. So naturally, 100% of women will go through perimenopause. 100%. Right? This is not a small percent. This is 100%.
100%.
Women will go through this. And a very large proportion of those people will have bleeding because of that estrogen dominance during that time. And they're talking about heavy, prolonged bleeding to where they're in the ER, they're getting blood transfusions, they're getting DNCs, and then finally, okay, let's do the hysterectomy. And so it's, gosh, if you just give them progesterone, we could avoid all of this.
What about even endometriosis?
Right.
There's a stage of also estrogen dominance.
Yeah.
And I don't want to oversimplify endometriosis, but
Right.
the point is that we're talking about women whose hormones are not balanced way before. Listen, it was a transition for me too. First was understanding the postmenopausal women with hormones. That was not clear to me from conventional medicine. That, again, was my wife's journey. She's older than me, so she got there first. And I was like, what happened to my wife? And then, oh, that's what happened. But then it's the understanding that the perimenopausal has to happen. I just want to make sure that our audience is aware. When we're talking about estrogen dominance, I'm just re-saying what you're saying, right? We need to have a balance. Everything is balanced, progesterone, estrogen. If progesterone is naturally slowly going down, even if your estrogen stays the same, you're suddenly going to become estrogen dominant. There's a lot of stuff that happens with estrogen dominant. It's bleeding. Endometriosis is part of that. Fibroid is part of that. And so a lot of the things that you think, oh, it's just happening, it's happening because no one's replacing this thing that's slowly declining. Menopause doesn't happen overnight. It's not, hey, period's done, great, now they're shut off. It's happening. So putting in progesterone early is really important. And then sometimes you need estrogen towards the late part of your perimenopause as well. So I have a question for you here. This is something that I tackle as a clinician, and I hear people coming all the time and say, I want to get my hormones tested. What do you do for that patient? Because what I do for that patient is I say, we can treat this symptomatically. I don't know that we're necessarily going to capture it in the testing. What you do?
Yeah, I've done that before. Generally, like if people are coming to me wanting their hormones tested, they're a new patient to me. So I just do like a big comprehensive blood panel, because I'm going to check also the thyroid, because it's like, what's making you think you need to get your hormones tested? Maybe it's your thyroid. And I always check the CRP and inflammation marker, just like a vitamin D level, because everyone's low. So I just do a big panel, and that includes hormones.
But what are you getting from the hormones? Are you checking estradiol and progesterone? What are you yielding from, especially if they're somewhere beginning, end of cycle?
Yeah, I always check, and a lot of people don't realize this, that there's 3 forms of estrogen, right? Not just one. I generally check the type 1 and type 2, I know, but just
tell everyone, break it down, please.
Estrone. So there's 3 types of estrogen, which you could call E1 or estrone, E2, which is estradiol, and then E3, estriol. E2, which is estradiol, gets all the glory. This is like literally the only thing that your OB might replace for you. But E1, which is estrone, I always check, because I call it like a bad estrogen.
Yes.
This one can get high. So I'm mainly interested if this one's high. And if it's high, one, it's still bad because it can lead to breast cancer and things like that. But it's generally linked to gut health and things like that. So I don't like to see that as liver metabolism. So I check that one just to make sure it's not high. I check E2. E3, we don't worry about as much initially. It is important as you get into menopause because when I do replace estrogen, which is late 40s, early 50s, typically, I do a combination estrogen, usually a cream called Bias, which is actually E2 and E3. So remember, E1 is bad. We don't really want that high. But again, E3 estriol is neglected again by your OB because E3 is really important for like vaginal tissue, vaginal health. And so what happens is even if a woman's on E2 replacement, maybe their doctor gave them a patch or something, they can still really struggle with recurrent UTIs or vaginal health or really pain with intercourse because that tissue is really breaking down, atrophying. So usually I'll replace E2 and E3 with a topical estrogen. Yeah, so when I check it, I'm checking estrone to make sure it's not too high, estradiol, and then I'll usually do at least a total and a free testosterone, like sex hormone binding globulin,
Sure.
and then progesterone. But with that caveat, like you're saying, you could treat it symptomatically. I'll only do the blood test once because it's not my preferred method of checking. And the truth is, when they come to me at a certain age, whatever that age is, I already know what.
Right.
So it's
Right.
like reinforcing, right? Like I already know if a woman is around 40 to 45 and she's coming and saying I'm having hormone, I already know I'm going to give her progesterone.
That's what I'm saying.
The
You already
lab
know. You already know you're going there.
to
She
me.
tells you she can't sleep. Can she have Ambien? You're like, no, you can have some progesterone. Like, yeah.
It might also tell me maybe some of this fatigue is either low testosterone because testosterone's kind of the wild card. We know
Testosterone, yeah.
when progesterone's going to drop. We know when estrogen's going to be later. Testosterone's a wild card. Like we talked about, there's some women who are younger in their 30s that are dealing with just crazy low level. And I have women that made it all the way into menopause and their testosterone is still okay.
Yes. Yes.
So that's part of why I'm testing too, because that is a wild card. And then again, thyroid, totally different topic. Totally not
Yes.
understood or treated properly by
properly.
medicine. So I always do a comprehensive thyroid panel because could that be involved in some of your fatigue or hair loss or sleep issues, infertility?
So just saying it back, because it sounds like we're on the same page, with the exception of estrone, which I don't really test, but I want to talk about what to do when it's high. If you're testing for E3 and E2 and progesterone, you're not really, you're going to treat symptomatically. Like you're not getting much because especially you don't really know where they are in their cycle. And then you don't need it to continue to treat also.
Yeah.
If you're giving 100 milligrams and they're sleeping better, great. If not, you can go up to 200.
Yeah, so I do a lot of titrating by symptoms. And at some point,
it's no longer the hormone.
Yeah. And so initially, like I always say start low and go slow, right? Like it's always better to start low and then titrate up than you can overshoot and actually give people a lot of the same bad symptoms. Actually, you're on the other side of the bell curve. So I start low and then usually by their symptoms, okay, go ahead and go up a little bit.
More.
Go up a little bit, like whatever. At some point, usually I will retest, but what's really important is how you test. So this is really misunderstood, especially by mainstream doctors.
I had to cut it here because that's just part one of my conversation with Dr. Camille. And if your jaw's on the floor, you're not alone. From military medicine to the ER to nearly losing everything and then rebuilding it with a single hormone no one was paying attention to. In part two, we go even deeper. Hormone testing, estrogen metabolism, thermography versus mammograms, and what it really means to prevent disease before it starts. As always, you can go on my website, drafratlamandre.com, to get my courses, to get my book. If you're interested in working one-on-one with me, please apply to my waiting list. If you're interested in merch, go on to my website to the store. And if you're a nurse practitioner looking to level up, go on my other website called egprep.com. Wherever you are, don't forget to subscribe, share this episode, and leave a review. It helps us reach more disruptors like you. Until next time, keep questioning, keep learning, and keep disrupting.